Hello, I am Parker Carte, and I am presenting Opioid Use Disorder, a multifaceted approach. Since the summer of 2019, Dr. Scott Galster, Vice Chair and Director of Applied Research at the Rockefeller Neuroscience Institute, or the RNI, and Professor of Neuroscience at WVU's School of Medicine, has been my mentor. Before I start, I'd like to thank him for all of his help, support, encouragement, and the incredible research opportunities. So let's begin. Opioid use disorder. When you think of that term, a number of things probably come to mind. Maybe you think of poverty-stricken neighborhoods. Maybe you think of an individual who can't get through the day without taking Xanax. Maybe you think of a family that is ripped apart at the seams because a young adult has fallen victim to opioid use disorder, or OUD. So all of these examples are accurate representations of OUD. In fact, each of you probably knows someone who has or is living out this tragedy. Wherever you go in the United States, you will find opioid use disorder. The fact of the matter is that it's a pandemic, and there's no other way to put it, really. Like many diseases, it does not discriminate between socioeconomic class, gender, or age. Anyone can fall victim to this horrible disease. For example, 15 million people are suffering from OUD right now, and 130 people die every day from OUD. And as some of you likely already know, West Virginia leads the country in opioid overdose mortality per capita with 49 per 6 per 100,000 people. That's actually comparable to the bubonic plague. While this is obviously very grim, there is hope. The Rockefeller Neuroscience Institute here at West Virginia University is currently working on groundbreaking research to combat this pandemic that struck our home. I've had the privilege to participate in some of this research. But before we delve more into that, first, some history about the RNI. The RNI was established in November of 2017. Its purpose and mission are focus and dedication to improving lives by pioneering advances in brain health. As always, we must give credit to these individuals for helping establish this wonderful institute. Senator John D. Rockefeller IV and his family, Dr. Gordon Gee, president of WVU, and Dr. Clay March, executive dean of health sciences. Thank you. So, to put it simply, at the RNI, our mission is to improve lives by pioneering advances in brain health. All right, so this will be on the test. Is the opioid epidemic a problem or not? Yes, it absolutely is. It's a public health emergency. As I've already mentioned, 15 million people are suffering from OUD every day, and 130 people are dying every day. It's obviously very bad, and West Virginia leads the nation, unfortunately. However, before we can actually do anything about it, we have to define our terms. We have to classify the problem. What is an opioid? Well, it's a class of drugs that are both legal and illegal. Obviously, heroin, for example, is in the illegal category, but other drugs such as morphine, methadone, fentanyl, and oxycodone are legal prescription drugs. So then we have the D word, disorder. It's a hefty word that holds a lot of meaning. So what does it actually mean to have opioid use disorder, or OUD? Well, obviously you have to be misusing opioids, and you also have to be experiencing severe impairment or distress. Actually a relatively new diagnosis, however, first published in the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5, in 2013. To clarify, the DSM-5 is the manual used for assessing and diagnosing mental disorders. It combined opioid dependence and opioid abuse. So in order to actually get diagnosed with it, though, you have to be experiencing two or more problems in four areas. Loss of control, social problems, risky use, and pharmacological problems are the four areas. And you have to be experiencing these within about a 12-month span. So, as with any disorder, it exists on a sort of spectrum, hence the distinction here between mild, moderate, to severe you see here. Mild is 2 to 3 symptoms, moderate is 4 to 5, whereas severe is about 6 or more symptoms. Moving right along then, chronic OUD can actually lead to brain abnormalities. More than 2 million people suffer from OUD in the US and require extensive long-term medical treatment. However, there are signs and symptoms that can help identify someone needing treatment. These include, but are certainly not limited to, confusion, drowsiness, and weight loss. They can also affect a person physically, emotionally, and mentally. But what can we actually do about all of this? Well, there are treatments, and they vary. A lot of medical treatments run into problems when patients suffer from withdrawal and cravings. There's also therapy, counseling, inpatient and outpatient treatment, but treatments are often paired. The biggest problem, however, is that the traditional treatments are not always effective. As a result, new approaches are needed. And one of the most recent at the RNI involves use of deep brain stimulation, or DBS. So The RNI is the first in the entire nation to attempt to use DBS on treatment-resistant OUD. The first patient was admitted on November 1st of 2019. Now bear in mind that I had little to do with the DBS procedure, but I did learn a lot about it, and I was actually involved in some of the preliminary opioid research. Here I'll briefly show a picture of the operating room where Dr. Razai performs the procedure. For patient confidentiality, I'm not going to show the patient's picture, but the patient's face is shown on a screen across the room to the right where you see the whiteboard. Researchers in the room are tracking the patient's eye movements using eye motions tracking technology and software, and that's actually where I did work and putting together the equipment and met with the people at the RNI, and also at Chestnut Ridge, as they use the technology to work with patients in the trial. So the principal investigator is Dr. Ali Razai, the executive chair at RNI, and but really it was a multidisciplinary project that involved experts from many, many, many different fields. Moving right along, though, what exactly is DBS? So it starts out with a craniotomy. It's an opening in the skull about the size of a nickel. The patient was awake. And that's necessary in order to provide feedback to Dr. Razai. So DBS is essentially a brain pacemaker. This is where the neurosurgeon implants 4 tiny electrodes in very specific areas of the brain. In our patient's case, it was the nucleus accumbens, the addiction and reward center of the brain. So whenever electrical impulses are administered to this part of the brain, it regulates those structures of the brain, hopefully the way that we want it to. It was about a 7-hour procedure done on November 1st, 2019. So what will DBS actually do? Well, it sends a pulsed current through electrodes implanted in the brain. It is believed that this will actually regulate the imbalance in the patient's reward circuitry. It also may prevent the patient's condition from getting worse, because without DBS, cravings could continue to actually become stronger. The physician adjusts the current using wireless technology. Stimulation to the nucleus accumbens is adjusted based on the patient's needs. It may need to be increased or decreased. This is typically done by a neurologist. So one of the biggest points, though, of doing this, aside from everything that you've seen thus far, is to ultimately put an emphasis on evidence-based treatments for OUD. Traditional treatments aren't really effective for all patients. The first phase of the clinical trial involves 4 patients. Selection criteria is very strict. They must have failed at multiple levels of WVU medicine's comprehensive treatments, such as residential treatment programs, outpatient treatment programs, medication, psychological interventions, and social recovery efforts. Hopefully, DBS will be an effective and life-saving approach to OUD and eventually become the standard of care. So we'll now delve more into the actual use of DBS. While the RNI is investigating the mechanism for addiction, U.S. Food and Drug Administration, or the FDA, has approved it for other conditions such as Parkinson's disease, essential tremor, dystonia, epilepsy, obsessive-compulsive disorder, or OCD, and the RNI routinely uses DBS for patients meeting these FDA guidelines. So about 180,000 people worldwide actually use DBS as a treatment for FDA-approved diagnoses. So the goals of the initial pilot study were actually to demonstrate that the technique was safe. So after that, a full-scale clinical trial can actually be conducted. This approach is directed at a very small percentage of opioid abusers. These patients have the most treatment-resistant opioid cravings. They face a lifetime of overdoses and relapses. They also have an inability to hold a job typically, and many other consequences of addiction. The fact of the matter is, however, we don't know everything about DBS. This is the whole point, though. We know DBS helps, but we also know that it's extraordinarily complicated. This is a large part of why this study was conducted. As Dr. Razai stated, quote, "The exact mechanisms are not known. By modulating the reward circuit, which relies on a chemical messenger called dopamine, you're getting better controls. You're not craving dopamine as much." End quote. So yes, it's complicated. We don't understand it entirely, but we do know that it helps. DBS for everybody, though? No, it's not. It's invasive. It's cutting edge. For now, it's for people who have been resistant to all other treatments. After all, it is brain surgery. So now we're going to turn our attention to focused ultrasound, another part of the RNI multifaceted approach to treating OUD. So this is a new experimental treatment. It involves the use of focused low-energy ultrasound, but don't worry, we'll get into what that means. It's a non-invasive approach, though, that has shown significant promise. First and foremost, one of the biggest challenges in treating any brain condition is the blood-brain barrier. The blood-brain barrier prevents things such as bacteria, germs, and also typically drugs from entering the brain. That's the whole problem, though, isn't it? how can we effectively treat conditions non-invasively without being able to administer drugs into the brain? Well, that's what focused ultrasound accomplishes. So here I've outlined two different types of focused ultrasound, the kind that the RNI is dealing with right now. So you have high-frequency focused ultrasound, or HIFU, and low-intensity focused ultrasound, or LIFU. The RNI is one of the 5 places in the world to have both. HIFU has been around for longer than LIFU. It's used to ablate nerves at very targeted areas. It's non-invasive, so it's not brain surgery. For example, it is used for treating essential tremor, but only after all the treatments have failed. It only takes about 2.5 hours. We conducted the first procedure in West Virginia a few months ago. LIFU is relatively new. It can also target a very specific location in the brain, however, without heat, because whenever you have high-intensity ultrasound, you're going to get heat. In Alzheimer's disease, the target is the vasculature in close proximity to a beta amyloid plaque site. Beta amyloid is the protein that is very common in Alzheimer's disease. Microbubbles are injected, and the LIFU causes those bubbles to oscillate at the target location, causing the blood-brain barrier to open temporarily, thus allowing larger molecules through that normally don't. These large molecules are thought to clear out those plaques. In addition, LIFU is used to calm down overactive neurons near the nucleus accumbens. In this case, though, it does not open the blood-brain barrier. It uses low-intensity oscillating ultrasound waves to temporarily open the blood-brain barrier in another case, though, to allow for very specific and targeted drug treatment. As I said here, in simple terms, it shakes up dopamine production. So sometimes LIFU will open the blood-brain barrier. Other times it will not. It just simply depends on how you use it. Now we're going to move on to repetitive transcranial magnetic stimulation, or RTMS. This is yet another new experimental treatment that shows significant promise. Essentially, it uses magnetic waves to cause stimulation of neurons in specific areas of the brain. This has been shown to actually decrease cravings in opioid addicts. This is another area where I was involved in cure reactivity research to help determine things that would be shown to a patient during their treatment. I'm just going to go ahead and quickly outline a course of treatment that was used on a patient with RTMS. So, the patient is shown a video of a person shooting up heroin drugs of some kind. So that activates the patient's brain. The trial participant's brain becomes very active in urges and cravings whenever this happens. Then, at this point, RNI researchers will use magnetic stimulation to reduce the cravings. The trial will continue to be expanded to include more patients in the future. So, as we look at the goal of RTMS, Dr. Razai sums it up really nicely. The goal is to, quote, reduce the cravings by modulating the reward center, or the craving center, of the brain in severe addiction patients, end quote. Pretty simple. So RTMS and OUD. So RTMS was used for opioid use disorder. It was administered in 7 separate sessions. It targeted the left dorsolateral prefrontal cortex, or the DLPFC. Again, cue reactivity, this is the part where I worked, was used, and substance-related cues were presented. Prior to and during and following the RTMS sessions, that patient engaged in subjective ratings. So the patient rated his subjective cravings using a 100-point visual analog scale. Researchers compared the patient's cue-induced craving ratings, and there was found to be a reduction in craving for heroin and cocaine. The patient experienced a decrease on average between 60% and 82% following 7 RTMS administrative sessions. Further investigation of RTMS is obviously warranted, but just to put it really simply, RTMS was shown to actually decrease the patient's cravings. This is very, very, very significant. Finally, there is one last non-invasive treatment that I will briefly cover, medication-assisted treatment, or MAT for short. It has been effective in enhancing treatment-resistant retention of OUD. It resulted in a decreased frequency of opioid use, but now we have to investigate novel interventions that will augment MAT. So MAT it's not really effective by itself. You need other things in addition to MAT in order to actually have the effects that we have shown here. But really, just in conclusion, addiction is a complicated issue. We're a long way from curing addiction and just as far from truly understanding it. We do, however, understand that there are both genetic and environmental factors that play into who the unfortunate victim of OUD will turn out to be. In order to put this knowledge to good use, however, additional resources are necessary. We need to be proactive rather than reactive. Developing more aggressive treatments and ensuring that all individuals have full access to these treatments is the next step in fighting OUD. The RNI is the face of the future in treating OUD. We hope to eventually see wearable technologies that allow us to predict addictive behavior, enable the patient to take measures themselves to nip it in the bud so they can actually stop cravings before they start. We also hope to utilize virtual reality technology to better understand and treat addictive behavior. We hope to teach and enable those suffering from addiction how to get through cravings without actually turning to drugs. As Dr. Razai talks about future research with the RNI, he says, quote, "We're going to take a serious approach at this, and we're doing it. We're going to try and tackle addiction in a coordinated fashion, but we have our work cut out. It's a very difficult problem, but we're not giving up because a lot of families need help." So this is proof that there is hope. Change is on the horizon, and this is where it's happening. I could think of no better way to close this presentation than with another quote from Dr. Razai. Quote, "We care deeply about our patients and families in West Virginia, across the country, and around the world. Our boldest aspiration is to make their lives better, one person at a time." End quote. These are my references. Thank you all for your time and attention. It was a pleasure presenting for you all today. Stay safe. Stay healthy. Thank you.